get it.
Good afternoon, everyone. I welcome you to the free JOGI web series Clinical Pearls of JOGI, our 9th episode today. To begin with, we start with Saraswati Vandana.
Om Saraswati Namo Namah Ma Saraswati Namo Namah Vidyadayani Namo Namah Hansavahini Namo Namah Om Saraswati Namo Namah Ma Saraswati Namo Namah Vidyadayani Namo Namah Hansavahini Namo Namah Om Saraswati Namo Namah Ma Saraswati Namo Namah Vidyadayani Namo Namah
So I now would like to invite Dr. Madhuri Patel, the Secretary General FOXY and Editor-in-Chief Journal of Obstetrics and Gynecology of India, to give a welcome address. Madam is joining us all the way from Trichy. So over to you, Madam.
Thank you, Pragna, for your kind words. Respected our President, Dr. Jaideep Tan, Madam Sadhna Desai, my mentor, and she has taught me a lot when I was under her as an assistant professor, lecturer. And I remember whatever she has taught, it is really helping me in my practice. So, Madam, thank you very much for joining for this webinar. Then Atul Munshi sir, my another mentor, I have learned a lot from him. So thank you very much for joining with us. And of course, Madam Usha Krishna, she is another guest of honor. She will be joining soon. And she is also a great, great teacher. And I also learned from her many things. Then, of course, Dr. Charmila. I was Madam Sadhna Desai, Usha Krishna Atul student, and now my student, Dr. Charmila, is here. She is today, going to chair the session along with Atul sir and Dr. Nidhi. She is going to chair. And I would like to say, dear friends, that this clinical pulse of JOGI, we started when, I took over as an editor-in-chief. And I felt, and we felt that, why not to give a chance to our members who have published. Our members are not only our FOXY members, but other members all over the world. Many of their articles are published in our journal, including review articles, systematic meta-analysis. We thought, why not to give them a chance and, let everybody learn from them how they went for the research methodology, what happened, whether it is useful. So you get a direct connectivity with them. That was the whole idea about it. Today is the 9th episode. And selection of the papers we have done, that the award-winning papers. JOGI has award-winning papers every year, and we have taken them as for our clinical pulse of JOGI. Every time we present 2 papers, and the authors themselves present this paper. So we found this very, very interactive session. Last time, our foreign author from Indonesia, we had asked her to talk about a systemic review on rectal sonography for the diagnosis of the cancer cervix. She talked so well, and there were many, many people who joined. So this program is going on very well. We get many of the, comments on that we should continue, because the authors, they never get a chance on the platform, where in the conferences, and if they're present in the paperwork, only, few of them are there to listen to them. So this is another platform where they are getting. With this, I would request our MOCs to continue the program. Thank you very much for giving me this opportunity.
Thank you so much, Dr. Madhuri Patel, ma'am. And really, I can't believe this is the 9th episode. We have had 8 successful episodes, and this all started. This program was a brainchild of our editor-in-chief, Dr. Madhuri Patel, ma'am, when she took over as the editor-in-chief of JOGI. And for this program, we have our chief guest, Dr. Jaideep Tang, sir. Maria, can you display his slide, please? Dr. Jaideep Tang, sir, we just had the presidential conference, and we all know, sir, he is the chair of YGA Committee OFOC, Project Lead FOXY, immediate past Deputy Secretary OFOC. Sir has been in the FIGO Committee, past chair for Safe Abortion, past chair, Newsletter Committee and Publication Committee OFOC. He is a consultant at Ashwini Maternity and Surgical Hospital, Center for Endoscopy and IVF, and he is the independent director on the board. And sir has been instrumental in drafting various proposals for FIGO, reducing C-section rates, propagating the ART bill, surrogacy bill, including changes. Sir always conveys his best wishes. He couldn't attend in person, but he's conveyed his best wishes for the program. Our guest of honor for today, Dr. Usha Krishna, ma'am. Madam has been the past president of FOXY. She is known to all in the field of OBGY. She has a vast experience in fertility control, safe abortions, high-risk pregnancy. She is deeply involved in medico-social work, and she set up a nursing college in Aurangabad. Skill development for adolescents in Jagruti at Research Center of KM Hospital, Pune. So ma'am has contributed to skill development of tribal children. She's a director Clinic for Women, Mumbai, consultant at Breach Candy Hospital, Bhatia Hospital, chairperson of ICMR and Ethics Committee. We welcome madam. Our next guest of honor for today are, do we have madam here? Would she like to speak?
You want me to speak?
Usha Krishnan,
No,
ma'am.
but
No, madam is not there.
She
Her
will try
assistant.
to join. She has some technical issue. She's
Yes.
conveyed she will try to join as soon as possible. In the meantime, I have the honor of introducing our guest of honor, Dr. Sadhna Desai, ma'am. She is an emeritus professor, Department of OBGY at Bombay Hospital Institute of Medical Sciences, honorary physician to Governor of Maharashtra. She's a consultant at Breach Candy Hospital, HN Reliance Hospital. She's the director of Fertility Clinic and IVF Center of Mumbai. Madam has been the past president of ESAR, past president FOXY, and has been an undergraduate and postgraduate teacher for several years. We welcome you, ma'am, and request you to please share your pearls of wisdom with us.
Hello, friends. It is my pleasure to address this academic-oriented gathering on the inauguration during the 9th episode of JOGI's web series called as Clinical Pearls of Wisdom. As usual, in this series, there will be a discussion focused on two important scientific contributions made by Indian authors published in our very own Journal of Obstetrics and Gynecology. So this is very remarkable. I find that we have reached very far in academics. This scenario of talking about our own publication might have been seemed very far-fetched just few years ago. And today we can very proudly talk about what we are doing in academics. I recall my good old days in late 1980s when I was just upcoming infertility specialist. And maybe at that time, you were just toddlers or not even born. At that time, we 12 friends in gynecologists, namely Dr. C.G. Saraya, Dr. Nargish Motasha, Dr. D.K. Tang, Dr. Shirish Sheth, Dr. Ganatra, and upcoming infertility specialists like myself and Dr. Meru Vansudi. So we 12 friends decided to meet once a month on dinner and drinks to discuss two groundbreaking research publications published in any renowned international journals, and we would discuss it at length once a month. These sessions not only enriched our knowledge but also sparked inspiration. This discussion also helped us in our clinical practice and our thinking. I would like to quote one incident about our journal reading meeting. In one of the meetings in those years, we read an article of diagnosis and management of HELP syndrome. You know, in late 1980s, HELP syndrome was not a very well-known entity. And we discussed with interest all about how to diagnose and how to treat. Now, as the fate would have it, after 3-4 weeks, a patient was referred to me, a young girl, 38 weeks pregnant, in the ICU in Bombay Hospital with difficulty in breathing. She could not even lie down. She hardly had urine output. The kidneys had shut down. Her platelets were very low and her liver functions were very raised. So when I saw the patient, I immediately realized that this was a case of HELP syndrome. So I told the intensivist, look, this is a case of HELP syndrome. You please quickly arrange for platelets, revive her immediately, and I would like to take out the baby. So the intensivist had never heard of HELP syndrome. So she looked very shocked at me and said, Adam, if you take out this baby, patient will die. You know, she never thought that this patient can ever be operated upon. So I said, look, I'm not operating right now. You just give her some platelets. Then I decided it's better to talk to a hematologist. So I telephoned Dr. Sunil Parekh. He was a very well-known hematologist at that time. And I told him, Dr. Sunil Parekh, I'm dealing with a case of HELP syndrome with very, very low platelet count, and she is not in a very good condition, and I require to terminate the pregnancy. Please help me to get some platelets and plasmas and blood and all, because her hemoglobin is also low. So there was no answer from his end. He was mum for a few minutes. Then he said, okay. Then he referred his books. He had also not heard about HELP syndrome. See, he opened his books and journals and he agreed that this is a case of HELP syndrome. So he came down to my help, and after giving her platelets and all, I brought the patient in a sitting position in operation theater and in semi-reclined position under local anesthesia. I took out the baby. And once I took out the baby, patient's breathing improved, her oxygen level went down, she could breathe on her own, she started passing urine, and in 24 hours, she recovered. So it is rightly said, publish, read publication, or perish. So it is important that it is very gratifying to witness the current transformation of our academics and scientific publication. India has always been known for its sheer volume of cases handled across various fields, often surpassing other nations. What was missing was a systemic approach to document, analyze, and present our findings in a format that could meet international standards and to gain recognition from the editors and peers alike. Today, it is heartening to see Indian authors are not only publishing data in the domestic journals, but also making significant impact in leading the international journals and conferences. This shift has paved the way for growing recognition of the Indian perspective. So I'm very happy that things are changing good for India. I am sure activities like reading and discussing scientific articles by our own colleagues in our own journals will inspire budding clinicians and postgraduates to collect their own data and publish it in a peer-reviewed journals. As we celebrate these achievements, let us continue striving to enhance our research and contributions to the global and knowledge with dedication and pride. I congratulate the editor-in-chief, Dr. Madhuri Patel, and the President Foxy, Dr. Jaideep Tank, for such an innovative initiation. Thank you very much.
Thank you, madam, for your such a kind words. And you have explained how you started with your 12 friends and how you got into the detail of the our cases, and you could save so many. Not you gave us the example of one patient, but you must have saved so many patients, and that's why we are proud as a student that yes, we have learned so many things from madam. Madam is not going to wait till end because she has patient waiting. So I have requested madam, and now again I'm requesting only few comments on our second paper, madam. Hysteroscopy, role of hysteroscopy after one IVF failure in rural area. Madam, can you share your this? So then we can start our paper presentation.
See, let me tell you, because I have read that article. So let me tell you, it's a beautiful article from an institute which is dealing with rural population. See, most of us follow the guidelines from Royal College or American College, whatever their guidelines, and we want to do evidence-based practice. So in recent years, the guidelines says that the sonography is so much advanced that there is no need to do hysteroscopy, that most of the time on hysteroscopy, on sonography, only if you find some pathology, do hysteroscopy. But if the sonography is normal, there is no need to do hysteroscopy. Some of them say if 2 failures of embryo transfer take place, you may consider hysteroscopy. But in olden days, when the sonography machine was not well developed, I used to do hysteroscopy routinely before even doing IVF. So now the sonography machine has developed, but I'm sure that in all the areas, rural areas of India, that hi-fi 4G, 5G sonography machine may not be there, and we are likely to miss the pathology and unnecessary spend patients' money with an IVF failure. So it is a very good idea that we should have our own guidelines when to do hysteroscopy. And I think paper like this is very right in saying that at least you don't wait for 2-3 failures to do hysteroscopy. After one failure, please do hysteroscopy. Make sure you are not missing the pathology, because one of the commonest cause of failure of IVF is uterine pathology which is missed out.
Thank you, madam, for your pulse of advice to all of us. And we always remember you as far as infertility and other aspects are concerned. So, madam, thank you for taking out your valuable time and joining for this episode. Thank you once again, madam.
Thank you very much, madam. Let us proceed with the
Yeah,
program.
please introduce the chairpersons for the next session.
Respected seniors, faculty, and dear delegates, Albert says Gyori was a Nobel Prize winner psychologist. He once said, research is seeing what everybody has seen, but thinking what nobody has thought. These are the principles at which we work at JOGI. We welcome all of you. I'm going to introduce our senior chairpersons we are privileged to have for the program. I welcome Dr. Atul Munshi sir. He is ex-professor from CG, Gujarat Municipal Corporation Hospital at Ahmedabad, which is Gujarat Cancer Society NHL Medical College. He is past president of IMS 2010. He is vice president Foxy 2007. He's a senior leader of, at Foxy and has been working at various committees and programs. He's past president of Ahmedabad OBGYN Society. So importantly, he has been a representative to CEFOG 2016-17, and he's at editorial board of journals like Pediatric Oncology Journal, Journal of Midlife Health. We are privileged to have you, sir. Thank you. Next chairperson, Dr. Charmila Ayavu, ma'am. Currently, she is heading and having her leadership as a vice president Foxy 2024. She is vice president Trishi OBGYN Society. She is being a leader as well as a head for the various committees and chairperson for the various programs. We welcome you, ma'am. Next chairperson is Dr. Nidhi Gupta. She is our national corresponding editor at JOGI. She is working as associate professor at Department of OBGYN. She is alumnus from Safdarjung Hospital, New Delhi. Her special interest is adolescent gynecology and preventive oncology. She is being prize winners and award winners at many places, where as a gold medal from AOGD, Women Researcher Award, Best Editor Award, various other prizes. Of course, she is a reviewer at JOGI as well as other journals. We welcome you, Dr. Nidhi. I request chairpersons to introduce the today's speaker and paper presenters.
Thank you, Sunil. Before we introduce the speaker, I'll just say something, then later on my two colleagues will take over. Thank you for inviting in the 9th edition of JOGI, Pearl of Wisdom. Dr. Jaideep is not there, Dr. Madhuri, madam, and Dr. Sadhnaji. Very recently, it was a pleasure to meet all of them at Presidential Conference at Mumbai. Today, we are discussing two important topics published in JOGI. My colleague, Dr. Charmila and Dr. Nidhi will take one topic each. As editor-in-chief, at present, I am editor-in-chief of Midlife Health, an official publication of Indian Menopause Society. I feel this discussion of important topics from JOGI is a welcome initiative. The authors painstakingly research and submit the article. The editorial team and peer reviewer meticulously scrutinize, and after lots of correction, it is okayed for publication. So when publication occurs, you know that it has gone through so many things. So this type of detailed discussion is essential for boosting morals of all, the authors, the editorial board, and the peer reviewers. Dr. Madhuri, editor-in-chief of JOGI and Secretary General of Foxy, deserves the due credit for starting this initiative. Thank you once again. Small request, please stick to the time. I'll request who is taking over. Dr. Charmila is taking over, Dr. Nidhi first, and the speaker whom they are going to introduce.
Nidhi, can I introduce?
Yes, ma'am.
Okay. It's my honor to introduce Dr. Manisha Kumar, who will be the who's the speaker for today, as well as the author of the paper to be spoken about today. She's specialized. She's a director and professor in the Department of Obstetrics and Gynecology at LHMC New Delhi. She's a lead consultant of fetal medicine. She's also in charge of Nidan Kendra Genetic Labs. She specialized in medical genetics from SGPGI Lucknow. She's also an expert in fetal medicine from Barcelona, Spain. She's won several awards, and it includes the Genetic and Fetal Medicine Award of Foxy. And she's taken an observership in AIMS, Delhi. She's also won the Corion Award of Foxy in 2014. And she's been awarded the fellowship, DHR ICMR International Fellowship, and observership in Oxford, in UK 2024. Her research areas are in placenta, preeclampsia, stillbirth, birth defect, and artificial intelligence. Can we actually take up the first paper if it's okay? The hysteroscopy paper. Dr. Manisha?
Yes.
Dr. Nidhi.
Dr. Manisha is there?
Yes, I'm here.
Is it okay for you if you take the other paper first, or you'd like to do
Yeah,
that?
it's okay. It's okay.
Okay.
Dr. Meenakshi's paper. Dr.
Yeah.
Meenakshi, are you there? Yes, she is there. She is
Yeah.
there.
Uh,
Introduce her,
Asi.
please. Yeah.
Nidhi, please, you can introduce Dr. Meenakshi.
Okay. So our speaker is Dr. Meenakshi on histoscopy, the paper of role of histoscopy in the patient with previous IVF failure. And Dr. Meenakshi is, can I get the slide, please? Dr. Meenakshi is Associate Professor at the Data Mega Medical College, Nagpur. She has done her MBBS from Jabalpur and MS from Mumbai. And she has done the fellowship in IVF. So she will be presenting the paper. So Dr. Meenakshi, proceed with your slides.
Meenakshi, you can share your slides. You can share the screen. Any technical error, ma'am?
We are not able to hear you, Dr. Meenakshi.
You are mute, please unmute.
To take time, we can take the first paper. It's already 4:30.
Yeah. So Dr. Manisha, you are ready?
Yes.
Show your slide.
Okay.
Sunil, help her necessary for second paper.
Yeah.
So is my screen visible?
Yeah.
Yes.
Yeah. So at the outset, I would like to thank the organizers, Pearls of Wisdom team, and Dr. Madhuri Patel ma'am for inviting me for this. I think it was a very pleasant surprise to, invite me for this article. And I would just like to tell that while doing this study, Dr. Manju Puri played a great role in in raising this thing and designing and encouraging me throughout the execution of this study. So the topic is impact of action taken in response to stillbirth audit, a success story. So normally we know that stillbirth is a burden, but we must audit stillbirth. And why we should audit? We should audit because the burden is huge. We have 16 stillbirths. We have one stillbirth every 16 seconds. So that is a huge burden. But the important thing here is that most of it, could be avoided with improved quality of care. When you go about to see how you can improve stillbirth, we see that we start with counting of stillbirth. And the second thing is to find the cause. And the third would be to classify them. And then only classifying is not enough. We have to analyze them. And only analyzing is not enough. We have to think of some interventions and doing counting again. So this article is regarding all this and completing the cycle. So when we say perinatal death review, we mean that this means to evaluate the data and to institute corrective measures, because then only our stillbirth is going to reduce. So our experience with stillbirth data started with WHO Sero perinatal database that we started with many other countries. India was also a part, and among them there were certain Delhi hospitals. And it started in 2015. All stillbirths were counted, weekly audits was done, and we classified them as ICD 10 PM classification. But we looked even at the modifiable factors and we analyzed them. So when we looked at our data from 15 to 17, there was a slight decrease. And then in 1920, when the COVID started, it started increasing. So it was at that time when we sat together and we thought of doing certain intervention so as to reduce that. So the study objective was to find out the modifiable causes of stillbirth at our facility and to implement interventions using POC-QI methodology, that is point of care interventions, and to evaluate the changes due to it. So we define stillbirth as baby more than 20 weeks or more than 500 grams with showing no signs of life, because this was what we had done in our WHO study protocol. And FGR was birth weight less than 10 centile for the gestational age according to the 21st intergrowth chart. So this point of care quality initiative improvement has 4 core principles. The first step is to make a multidisciplinary team and to know the baseline data. The second thing is to identify what are the barriers that are there, and then to find out potential solutions to it. And that is called the PDSA cycle, which is plan, do, study, act cycles. And then we measure the data again to see whether it has reduced or not. So going by these 4 steps, we started with the classification and finding the baseline data. So when we we found the cause and classified, we divided the causes into maternal associated condition and fetal causes. And in fetal causes, again, the antepartum causes and the intrapartum causes. So these causes, when we tried to find out and analyze them for last 1 year, we found that there was antepartum deaths were more, but intrapartum deaths were almost half of it. So it was 50%. So it was quite more. And then among the antepartum deaths, we found that disorders due to fetal growth accounted for most of the antepartum deaths. And among the intrapartum deaths, we found that fetal hypoxia was the main cause. A most important cause. So keeping this in mind, we thought what could be the modifiable factors. So when we think of modifiable factors, there are actually gaps in care. So extra facility, we couldn't do much, but in the intra facility, the modifiable factors, we found that those which were provider related, we could do something about it. So among them, we had non-recognition of high risk, and because of not non-recognition, they were not probably induced on time or not being seen probably in a better way in labor. And the other most important thing was inadequate monitoring during labor. So we thought of acting on these 2 things. So we made, like in POCQI, we make a prioritization matrix. So in that, we look at things that require low effort and are of high value. So we categorize all the things, whatever we thought could be done. So we thought that whatever things we are of low effort and of high value, we can do them now. So in that, we had improved intrapartum monitoring. And the other thing was identifying FGR in the antenatal clinic. So we thought that these 2 things were main important things and they could give us a quite high yield. So we looked at what are the interventions, what are the gaps, what are the solutions, and whether they were feasible or not. So you make a chart like this, and then in the antepartum, we looked at the reasons why the FGR were missed. And we found that it would be examination when the doctor of various level examined the pregnant woman. So the solution that was given, so we make a good Google form to find out the solution, and all faculty were asked to give their suggestions. So we found that, okay, doctor at high level examine high risk patient, this was not possible because it was difficult due to reduced manpower. Then there were other suggestions also. So the suggestion which we found were quite good was the problem of failure to identify late FGR by limited sensitivity of the clinical assessment. We thought we could do a growth scan of all women at 35 to 36 weeks. And we thought that it was feasible, but we thought, okay, we will find out ways by which we can do it, but at least try doing this. So this was a feasible thing that we thought we could do. In the intrapartum monitoring, again, there were many problems and gaps that were identified, and there were many solutions. Many of them were not feasible, but we thought that if suppose if we have this problem of putting separate notes, and these separate notes took so much of time, and still there was so many times that there were no notes at all. So we thought if we have a common labor chart for all, it was quite feasible. And this indigenous labor chart could be in which all labor examinations would be written in a chronological order, could be better. And we just thought we could try this. And even this indigenous labor chart can be made by existing resources. So we didn't need extra resources. So we thought we could try these two things and just follow them up. So now came the step of intervention. So before doing an intervention in POCQI, you make an aim statement. In that aim statement, we thought that we would make an aim of increasing the percentage of women getting ultrasound done in the third trimester from 25 to 70% at the end of 9 months. Similarly, with using an endogenous fetal monitoring chart, we could increase our labor record percentage entry from 0 to 70%. So we had this aim, and then we started working on it. So the first thing was to shift the ultrasound machine to our OPD. So we shifted that. Then still after shifting also, many people didn't do it. So we constantly apprised them of doing it. So these were the PDSA cycles that we did. And for growth chart entry, we changed our antenatal card. We had put now the growth charts over there so that it can be entered and FGR could be noticed quite early. Now, in the labor chart, we made this indigenous chart in which everyone would enter at this whenever they would be seeing the patient. So this is a sample of the entry that was being done. So the step 4 was the process and the outcome indicator. So the process indicator was proportion of women undergoing growth scan at 34 to 36 weeks and proportion of women in which the common labor chart was used. How did we look at that? We reviewed the antenatal file of the patient when they came for delivery in the end of each month. So at the end of for the 24 hours, we could see how many cases was admitted, and among them, how many actually had the scans in them and how many had the labor charts in them after delivery. So we did this. And then we looked at the stillbirth rate also, and that was the outcome indicator. So when we looked at the median value, we found that there were 212 stillbirths at the observation when we had done the baseline data. And in the next 9 months, we had 165 stillbirths, and the p-value was significant, and therefore it has significantly reduced. When we looked further into our observation, we found that in the pre-intervention group, the number of antenatal checkups were far more, 62% compared to the post-intervention group, because this was the time where the second wave of COVID was there. So it was more severe and we had less antenatal checkups, but still we had less stillbirth. So that was very, good to know that this had actually helped. The second thing, our observation in the delivery was that the mode of delivery was the cesarean section rate was also less, because by the time we were more used to wearing gowns, and we would make like COVID situation was there for a long time, so we were more prepared. So the cesareans in stillbirth were also less. And the other thing was, important thing was even the weight, there were lesser patients with more baby weight in COVID in this post-intervention group, but still we had less stillbirth. So these two things, this less baby weight and less antenatal, both were the adverse things, but still the stillbirth rate was less. So this was good in a way. When we looked at the non-recognition of FGR, we found that in the pre-intervention period, the non-recognition was 22%, whereas it was just 6.8% in the later period, in the observation intervention period. And there was 63% reduction in the risk. And similarly, when we looked at the inadequate labor monitoring, like there was suddenly a loss of IUD, those situations were very less in the intervention period compared to the pre-intervention period, and there was 45% reduction in the provider-related delay on the whole. So if you will see our chart, so recently we again had some presentation. So I made this chart starting from the very beginning, 2015, how like these are the two, this is the COVID times. And then when we did our two intervention, how it helped. And now the stillbirth rate has become 10.4 compared to what it was, like it was 25, 26. In the first year, it was less, maybe because we had just started and the reporting was very less. And the intrapartum deaths contributed half, 50%, and now it is contributing to 25%. Although it's still more, but we are actually reducing, and that is a good thing. So coming to the discussion, the study identifies gaps and prospectively implements POC-QI related intervention to plug them by intervention. It steered an overall decrease in stillbirth rate during the second phase of pandemic, even though it was more severe. In a large population-based study, it was concluded that most of the stillbirths are avoidable, and the single largest risk factor of this is an unrecognized FGR. And this is the study which I've shown below, is by Mungeli et al. And Roma e et al. So the present study adds to this data, affirming the need for universal use of ultrasound growth scan at 34, 36 weeks as an important intervention to reduce stillbirth. So what is the ideal method of monitoring labor? An electronic tool in labor monitoring may not always be available in a low resource setting. So if it is a common labor chart, all healthcare providers, intern, resident, consultants were requested to enter the findings chronologically in the same chart. And as most stillbirth happened before active phase, a customized labor chart for monitoring pregnant women during the latent phase was even proved to be useful. And it needed no extra resources, and the headings and the columns ensured that no findings were missed, and the findings could not be entered retrospect. That was the most important part. So the the SRs and the resident had to see the patient in order to fill that labor room chart. So we looked at some articles, and we found that there was a stillbirth prevention bundle by a group in Australia. And most of the things that they talk of was already that we had also done. So it was good to know that. So they said that you can, in the bundle, you can have supporting women to stop smoking and improving the screening and surveillance that we also did, improving the awareness and management of decreased fetal movement, improving the awareness of maternal sleeping position, left lateral or right lateral, so lateral position, and improving the decision making around birth. And this also improved a lot. And we have been practicing this at present, and doing an ultrasound before inductions. And this has also helped. So the strength of the study was the purpose of audit. So the audit actually brings about a change. And in the present study, the implementation of this, intervention and doing this has really brought about. So this is the major strength. And the limitation would be that the background data and the impact of intervention were observed during the COVID pandemic, which might have some confounding effect on the results. And so to conclude, stillbirth audits are important to identify the preventable causes. Most preventable causes are related to the quality of care received by the woman, and quality improvement methodology is an important link that can plug gaps in the care. So we must start building our team. This is our team, and there are many more who have worked behind the scenes. Thank you so much. And all those authors who have been an integral part. Thank you. And thank you for patient hearing.
Sharmila ma'am, should I continue with this article?
No, I think I'll do this also, because I may not have time, because Madhuri madam, when she comes, I'm leaving for Karur. It's a society nearby. I am actually accompanying her.
Okay, fine.
So the thing is, wonderful work, Dr. Manisha. I would say, I think I have to thank Madhuri Patel madam for bringing out such a paper, because we always rely on Western data and we don't have an idea like how we can do in our own country. But tremendous work, and that it's so appreciable that you did it during COVID times, because
Yes.
COVID itself increased the stillbirth rates and perinatal mortality, but you were able to actually show better results with your interventions, and that's like a very, very appreciable. I had certain I think there's a question in the chat box, but I'll just ask,
Yeah.
like, you said you
Ma'am,
monitor
can I
during
just
the
interrupt?
yeah
Hello?
yeah
Ma'am, can I interrupt?
yes
Dr.
yes
Usha Krishnan Madam has joined,
okay
and her secretary has just could do the needful. She couldn't join at the time of the inauguration.
okay
So she would like to speak a few words.
yeah
Most welcome.
Hello? Hello?
yes.
Yeah, she has joined. I will just a minute.
Yeah, madam is joined. She's there.
Yes,
Good
yes.
evening, madam.
Yeah.
Good evening, Dr.
Good
Usha.
evening, ma'am.
Hello, good evening.
Good evening, madam. Thank you for
Welcome,
joining.
ma'am.
Now, I'm all with
Ma'am,
you
please.
and I want to listen to all that you tell.
Ma'am, would you like to say a few words for our audience, ma'am?
Now,
We
first, I
introduced
want
you.
to hear more, and I'm very happy that you have invited me. This is an excellent meeting, and I want you to tell more about your plans. Please do, please do.
We will summarize it then.
Arey bhai,
Yeah.
you speak and I'm be happy.
Thank you.
Tell me.
Okay.
Chandra,
Thank you,
Madam,
madam,
want
for
to say?
joining. Yeah. Yeah.
Madhuri madam wants to say
Chandra,
Can
just
something.
give background of this case so we can go for discussion. Because Madam Usha Krishna will also like to give her inputs.
Manisha, would you like to give a summary of that, Dr. Manisha?
Yes, yes.
Yeah.
So
Just
basically
summarize.
this, so basically this study was done in the COVID period, and we had, by this study, we have, first tried to find out the baseline information of our stillbirth rate, and then we tried to find the cause of, modifiable factors, what we could do to reduce it. So we thought of these two interventions. One was looking at the FGR, trying to find out more FGR cases by doing an intervention of doing an ultrasound in all women at 35, 36 weeks. So this was the first intervention. And the second intervention was doing, making a labor common chart for monitoring of labor. So we started from the latent period and we carried on. So we found that doing these two simple intervention helped in reducing the stillbirth rate. And this was done under the POCQI, guidelines. So there was like the aim and all, and then we found that the median level actually dropped. So this was a success story.
So you said you're monitoring during latent labor, but usually our monitoring is during the active phase of labor, no? So what made you monitor the baby during the latent phase of labor?
Yeah. Yes. So basically, when we analyzed our data, we found that when when we had induced the patient, like by Cervigel or by even by Foley's, we use Foley's quite often. So many a times, there would be stillbirth occurring, IUD occurring at that time also. So that was also an important, because monitoring is not as optimum as was taking place during the intrapartum, like active labor phase. So that made us think about monitoring, more stringent monitoring at that time.
What are the monitoring parameters in the latent phase, which tells you that there's going to be a problem?
Yeah, so basically it was just FHS monitoring.
FHS monitoring.
So basically it was FHS monitoring only and not much. And the progress of labor monitoring. So if the progress was suppose not taking place on anything, so we should be, knowing.
But in latent phase, we don't expect much of progress, no? So why should you monitor latent phase to find out?
No, not
whether
less
the
in
base...
progress. What I meant was about the methods that when you asked. So basically, in the latent phase, either we do a CTG monitoring once, or even if if we are using some other method. Suppose we are using Foley's and now we are using a gel, or we are going for MISO. So we generally do again. So when we change our method, we do it again. So these were the two things, and doing an FHS monitoring was the only thing.
Especially when you are doing it in a multiparous patient, you have to be careful. When you're inducing a multiparous patient.
But your study did not have the data on whether it was induced or augmented, or it was a spontaneous labor progress. Because I think that data should be there, no,
Yeah.
to say like
Yes.
which type of babies went for distress pattern.
Yes.
That was
So
the
we have analyzed again, as I said, we have analyzed our intrapartum deaths again. And now we have found very, good findings are there regarding when actually and where did we actually falter and where we can actually correct. So we will be doing more, make a paper on that again. So at that time, we didn't go so much into the depth of like we had these performers which we looked into and the files. But now we have again looked into just intrapartum and induced patients. So we have again with Dr. Manju Puri, I have, and with there are other residents also, and we have got together and we presented it in a Hyderabad conference of Stillbirth Society. And there it was quite appreciated that
Yeah,
we.
it's a very good paper. And the other thing is, we would like if you can get some data on like how prolonged is prolonged. Because American
Yes.
college gives us different guidelines. The Royal College
Yes.
says differently. We don't have any guidelines to say when active phase starts and all that. So
Yes.
suppose you can combine and give us a data on like how
Yes.
prolonged is prolonged. Because
Yes.
stillbirth
Yes.
usually happen when you keep on allowing the mother to be in pain for a long time. That's why we're seeing all that is
Yes.
anecdotal, but we don't have
Yes.
evidence to say that this much prolongation caused this much problems in the baby. So that
Yes.
if you can combine with your
And
monitoring,
and we had many patients in which there was fever, and after that the fetal heart rate was gone, fetal heart was gone. So
okay,
the fever was detrimental. So we have even made the taking into account different what was the precipitating factor. So now we are like we have done say around very few cases, around 30, and we would be doing more of the cases. So we have done just 2-3 years, and then we would be doing more and have more cases to understand what was the thing that actually precipitated before patient went.
Any viral infection will definitely give rise to
Yes.
fetal distress.
Yes.
Ultimately,
Yes.
death can also.
Yes. Yes.
so that
I-
doesn't mean if you have a patient with fever, you will deliver her with a cesarean or something. Does that the message there?
No,
then?
no, but
No, no.
yes, no, this is not the thing. But the only thing is we should be more vigilant whenever a patient. Not
Fever.
let the fever become so high. Basically, we should try and see that if the patient is maybe because of myso also they would be having the
Having
fever.
the fever.
Or
Yeah,
not
yeah.
necessarily it is because of infection. So we
Okay.
have to just take care of that and give hydrotherapy or something and take more care of the babies. If the mother
In a
is having.
busy center, all that matters because when
Yes.
you don't monitor mothers with fever and misoprostol is being given without a monitoring, that's going to cause more problems,
Yes.
definitely.
Yes.
And what about the comorbidities? Did you exclude them, diabetes, hypertension, in your mothers who had stillbirths? Because that will be a confounding factor, no? Because
Yeah.
with
So
the
in
with the metabolic
ICD,
disease, yeah.
yes, you're right. But here, what we did was we first made the causes where in ICD 10 PM classification, we have the maternal causes and the fetal
Fetal
causes.
causes.
So here we just looked at the antepartum deaths. Why did they occur? We didn't categorize them into hypertension and all, but all those who had late onset FGRs. Because early onset, like I have done study on hypertension and stillbirth, and it was a very good finding that I found that there were less stillbirth with preeclampsia compared to gestational hypertension. There
Hypertension,
were more
yes.
stillbirth with gestational hypertension, and it has also been published in the international journal. So, like these findings were quite, good in a way that we could, pay more attention to our gestational hypertension with regard to the baby compared to that.
Yeah,
So, you're
yeah.
right. Hypertension, of course, and FGR and hypertension are,
Because we are more vigilant when there's preeclampsia,
Yes.
thinking that
Yes.
proteinuria will cause more
Yes.
problems. But the reverse is like we have ignored gestational hypertension and the baby goes
Yes.
for a toss.
Yes.
By the time we go for monitoring in the second or third trimester, it will be quite late. So ideally, antenatal care should start from very beginning.
Yes.
Continuous monitoring, especially different people are saying it. A protocol should be made, as you rightly said, that you do it in labor. But it should be done in the earlier part also. Not that by the time 7 months, 8 months comes, you might be quite late for that.
But the late onset, FGRs are something that, that has to be tapped and recognized because they are generally missed. So the diagnosis has to be done. And symphyzofundal height is also a very good thing that we have started practicing. And, especially the graph, the rate at which it is increasing, or whether it is remaining the same or whether it is dropping down helps a lot. So now we
In
have that.
urban area with good sonography machine, other thing, we can intervene timely. In your case, when you are in a rural area, you have to timely do it with your clinical judgment.
True.
So in
Intervention, timely intervention is important.
So many patients, like they are like they get angry with us. We keep on asking for scans. So suppose you can say like, suppose you miss out, suppose there's no growth restriction earlier, and then you assume that everything is fine with your clinical judgment, and suddenly the baby goes for a growth restriction. I think that intervention of telling the patient 35 to 36 weeks, a growth profile will actually tell us how problematic it's going to be, because many times stillbirths happen with these growth late FGRs, because we always manage an early FGR quite efficiently, but late FGR we always careless because we feel nothing will happen, and we have seen stillbirths with late FGR usually. So
Yes.
wonderful information on that. I think so much of thought for everybody to now go back and do better in the labor rooms and
Thank you.
antenatal
Important
management.
part is impact of action taken. So that is also important.
very
You might
good.
diagnose everything, you might document everything, but if you don't take any action, so that's a good part of it.
Similar to the emotive trial, I think. It
Yes.
should become a bigger publication now.
All the
Thank you.
best for keep it up.
Thank you. Thank you, sir.
Madam would like to, Usha Krishna, Madam would like to say something about this case. Madam, are you there?
Enjoyed the discussion that you made, but I want you to tell what is the objective? What have you finalized after your discussion? Can you tell me the summary? I'll be very happy to know that. I can see that you summarized it, but I want you to know what
What
would
the
you
ultimate
say?
conclusion of your
Yeah,
What's
so
the
research?
conclusion? What was
ultimate
the
conclusion, I
conclusion?
think, is that most of the stillbirth is preventable. So if we can just go back and try to find the cause and try to see what we can do to prevent. So doing small steps can, help, and it will
That's right.
certainly.
That's right. So start. What are the preventive steps? 1, 2, 3.
So the preventive step would be if we find that FGR is a major factor. So first is to identify which is the major factor. So if we want to reduce that major factor, you have to you do your fundal height monitoring and monitoring the fetal growth. If we have found that this FGR is a major factor, suppose it would not be a major factor at some other place, but it is at our place. So in every place, the major factor would be different, and we could actually work on that and try to reduce that. Similarly, in not monitoring labor properly, we thought that most of things could be monitored, and we could really reduce the intrapartum stillbirth by monitoring. So what methods we can do? We have to think at own local level and then act accordingly.
You have brought the point that what method is suitable when. That's important.
True.
When
True.
would you use a particular method and how useful it is? Please tell me.
So, like I had shown, ma'am, in our case, the antenatal stillbirths, we could prevent by identifying FGRs. So we have been practicing, we have started practicing it, we are continue doing it, and we make a chart and we do an ultrasound at 35, 36 weeks.
Correct.
So this helps in planning the birth, either whether we want to induce early or you induce late. So you plan that way. So this helps that way. So this is one of the
Dr. Munshi, your suggestion?
Yes, good antenatal care is first. See, things are different at urban level and rural area. So what she is talking about is rural area, so everything may not be possible. But in our country, our type of routine antenatal care, regular follow-up, again, protocol you follow, because there are different people seeing. One day one doctor will see, another day another person will see. Monitoring the mother and baby during fetus, during the labor point, and timely intervention. These are important. And second trimester or third trimester, blood sugar level is very important, because sudden rise.
This point you have mentioned is very important, that you start monitoring from second trimester.
Yes.
Don't wait till the third trimester, because you start getting a good information from second trimester.
Right.
And you make your notes, follow it up, and write the summary of second trimester and what you must do in third trimester. Plan it.
Late FGR is not that very common. It's common in few cases, but that may not be that common. And we get hint very quickly if you are
Yes,
regularly
we-
following up.
Yes, yes. You can
Uh,
get the trajectory, how the growth is going on. If you
Yes.
start from the second trimester, then if
Correct.
you go to the third, like from 26 weeks onwards, you can get some idea about how the trajectory
So
is going.
that is important for prevention.
Yes,
Yeah, the preventive part is most important.
yes.
And somebody, one of you, speak on the preventive aspects and mention just 3 important points. Yes, Dr. Munshi, you tell us.
As I said, you regular antenatal clinic, follow it up regularly,
Yes,
monitor,
that's
monitor both, and blood tests around the during the labor. You have to be continuous monitoring should be there, and if possible, a person of some seniority must be there to judge, because younger person will first see whether it's right or not. Afterwards, they will try to contact someone else. So somebody should be there who can take the decision.
Don't say somebody. Can you specify what
Because I'm in a
person?
private practice, all my patients I see from beginning to
That's
end.
right.
But everywhere it's not possible, because when somebody is working on 8 hours duty, it is difficult to go for routine.
What more do your associates say when you mention this very important point? What more? What should be done?
So basically, other studies have also found that when you make patients aware whether the fetal movement plays a very important role. So recognize the fetal movement.
So
and
you have put
what-
one point, patient's awareness. And I think the whole thing revolves
Empowering.
around patient awareness.
Yes.
How many patients have come to us saying that I'm feeling lack of movement or increased movement, or the problem that I face is this. So we can think of the possibility of future stillbirth, future lack of fetal movements, etc.
So we routinely tell them to kick count routinely.
That's right. That's right,
Yes.
Mr. Munshi. This is very important. The kick count.
Sometimes because of too much of anxiety, almost every day one call I am getting that kam hai, zyada hai, yeah. So you have to convince them also that it is also some variation is also there.
So let's have a chart where we write down the 3 or 4 points. The importance of patient awareness. And which are the points? So, awareness related to fetal movements, kick counts, patient's general attitude of her own wellness, patient's feeling well. What else would you put it down here?
Can we go to second, madam?
Hello?
Sir,
Hello?
can
Sorry
I
to
say
interrupt.
something? Sir,
Yes,
can I
yes.
say something?
Please.
Yes, it was Dr. Manisha, it was a very good paper. And you showed that modifiable factors. And
Yes.
modifiable means late fetal growth retardation and continuous monitoring. Everywhere the electronic monitoring is not available. So how important they are. But I have one question with you, that you have done a late fetal growth retardation patient induction, right? So how many you found a late fetal growth retarded babies in your series? Because these
Yeah,
were you were doing routinely, right?
Yes.
35, 36 weeks, all the patient. So
Yes.
how high it was?
Yes, yes, ma'am. So exact number, like I have the data of FGRs, but not exactly the late onset, because when the patient used come to us, like our FGR depended upon, like when the baby delivered, the weight was less than 10 centile. So we called them FGR. But from how, like suppose a patient didn't come after 30 weeks. So we didn't know whether it was an early onset FGR or late onset FGR. So it was difficult actually to tell, but FGR we could actually tell, and I have shown it was the most important contributory factor. I can show in the slide. So we made this chart in which we showed that among the antenatal also the FGR was most important, and among the intrapartum also the FGR played a role, because in the ICD-10 PM classification we have FGR in both the groups. So we had a high number of FGR in both the groups. So that number we had, but whether they were early or late, it was difficult to find.
Important part is weight of the baby depends upon the mother and father also. So that also should be kept in. 2.2 kg my child might be normal, and 3 kg
Yes,
child might be
that of
premature.
course. So that's why we had mentioned that the FGR we had taken as less than 10 centile.
Yes,
But yes, you're
definitely. By
right, sir.
definition, it's
That
all right.
could be one of the limitations, that we didn't go by the Delphi criteria or FGR, but we went only by the less than 10 centile. That is by ACOG, ACOG.
Madam, can we go for second one?
One query, can I
Sir,
ask?
one more question I will ask, sir.
Okay.
I just wanted to know, these are all low risk patient and high risk patient mix.
Yes.
So, nowadays the study says that if they are low risk patient, you should admit them in an active phase of labor. You should not admit them in a latent phase of labor. Otherwise, gynecology obstetrician try to intervene more and more.
Yes.
And ultimately ending up with the vaginal instrumental
Yes.
delivery or cesarean section.
Yes.
So
More
you have shown that in your later phase, the stillbirth rate were high. So I just
Yes.
want to know that part.
Yes, ma'am. Yeah, you are right. We also have found that in this study only, we found that in latent phase, the deaths were more. And you're right, but we have not analyzed it as such. But of course, it has been seen that more you intervene early, and especially when we are taking the weight, and we are deciding that if it is not an FGR, naturally you will not admit the patient early. So that also helps in deciding your resources, and not doing early intervention if the baby is not FGR. So ultrasound and knowing the weight helps that way also, because you will not admit a low risk mother, and you will let them go beyond 40 also. So that is an important thing. You're right.
Can I ask
Thank
one?
you, Dr. Manisha.
Nidhi wants to
Thank
ask.
you, Dr. Manisha. We should take Madam Usha Krishna's, advice that you should start screening from second trimester. And as Dr. Atusha said, that you also have to take care of sugar and everything in a third trimester. So we have to add this point so we can come out with the more, details about the
Nidhi wants to
modifiable
say something.
factor.
Dr.
Thank
Nidhi
you.
wants.
Yes.
Yes.
Yes, sir. Thank you, sir. Dr. Manisha, ma'am, I want to ask that both the interventions have been done simultaneously or one after the one?
No, they were done simultaneously.
So
Simultaneously.
the data is the reduction in the stillbirth is the effect of either of one or the combination of one, we can't say. Maybe
Yes, yes,
the
we cannot say.
intrapartum monitoring has more effect on the decrease in the stillbirth rate rather than the ultrasound at 34 weeks.
Of course, because many antepartum, if we have detected FGR, that would help in intrapartum, reducing the intrapartum stillbirth also. Of course, we cannot say, and we did the two interventions
So
simultaneously.
mostly in
You are
quality
right.
studies, one intervention should be done at one time. Then after a few months, the second intervention should be done so that better predictor of which intervention has caused more effect.
But the end objective is to reduce. So it is better that we do both and then we do reduce. But you're right, you cannot say. But then there are multiple things that play a role in stillbirth, occurring of stillbirth, hypertension also, everything like monitoring of BP. So you cannot just take one or the thing. But this is what I feel. But of course, you cannot say what help more, because even
Scientifically, it should be
intrapartum
less.
stillbirth can be reduced by antepartum monitoring better.
Use your all resources to prevent.
Yes.
Very nice study, Dr. Manisha.
Thank you.
Thank you.
Nidhi, can you take up the second one?
Can we start this, introduce the second author, please?
Dr. Meenakshi has been introduced. Dr. Meenakshi, are you ready with the presentation?
I
Yes,
think I have introduced
Yes,
Dr.
sir.
Meenakshi before.
Yes, sir. Am I audible now?
Yes,
Yes,
you're
Dr.
audible.
Meenakshi,
You
you
can
will
share
share
the
the
screen.
screen.
Okay, sir.
think there is some technical error or something. She is not seeing.
Dr. Meenakshi, your screen is not visible.
Let me know if you have any challenges. There is option of share screen. Go into complete screen.
Dr. Sunil, I have shared her PPT to you. If you want, if she's not able, you can also share. Okay, done.
I think she started screen sharing. We can see your slides, Dr. Meenakshi.
Make it full screen
Yes,
and
ma'am.
please go ahead.
Okay, sir.
Slideshow, you can put it on slideshow.
Slideshow.
Start video.
Hmm.
Okay. No.
I think there is a network issue with Dr. Meenakshi.
I guess the
Is it-
speak might think so there is a network issue. There's a glitch there.
Yeah.
Maria,
Is
do
it
you have?
visible? Is it visible properly now?
Yeah,
It's
it is
visible,
visible.
but you
Go
have
in
to go to the slideshow. I think so there is a net
Actually, I
issue.
had already started slideshow. It is in the
So there is a
slideshow mode.
delay here actually.
There is a delay. There is a
Check your
glitch in
net
your
connection, Dr. Meenakshi. Internet connection.
You have to stop share and share it again.
Yes, please stop sharing and start again.
Okay, ma'am. Stop share. Share.
Now put it on slideshow.
वीडियो का छोड़ दो.
Sir, is it okay now?
Is there, but can you make it manual then? If it's not properly working. The second slide, third slide.
Just change the slides, Dr. Meenakshi. Go to the next slide, please. We can see if the slides are moving. No, I don't think that's happening.
No. Move नहीं हो रहा.
हो रहा ना.
Stop share.
स्टॉप करो फिर से करो. शेयर स्क्रीन में जाओ.
Hello.
Ma'am, I'm sharing screen again.
Okay.
I have
Try once more, otherwise
shared.
Maria will share.
Dr. Meenakshi, you can stop share if you're not able to do. I'll share your screen.
Ma'am, actually, I had finally edited some slides.
Yes, okay, we can see
Yeah.
now.
Now it's
Okay,
visible.
done.
Let's change now. Just change and see if the slides are moving.
Okay.
Go to the next slide, please.
Okay, ma'am. No, it's not changing. Second slide.
That's okay. You can tell the edits. No, Maria will share the screen. Whatever you have edited, you can speak out if it's not on the slide. Yeah, we can see now.
Yeah,
You
it's
are
moving.
It's
Yeah,
moving.
Please
moving.
go ahead.
Yeah,
Please
yeah.
go ahead.
Please start.
That's fine, yes.
Okay,
You
ma'am.
can continue.
Good evening, all the faculties. Today I'm going to share my present my publication, which was my article was published in the Journal of Obstetrics and Gynecology of India in January 2023. The title of the article was "The Role of Hysteroscopy in Patients with Previous In Vitro Fertilization Failure and Institutional Experience in Rural Population." Next slide. This is the first page of my article. Is it visible?
Yes, yes.
Yes,
It is visible.
completely.
Introduction. The worldwide IVF success rate is around 30 to 40% despite all new advances in treatment methodology since the first IVF baby was born in 1978. The success of IVF mainly depends on good quality embryo and the endometrium, where hysteroscopy may play a crucial role in an endometrial assessment. The assumed causes of repeated failure can be categorized as: first, factors related to decreased endometrial receptivity; second, factors related to defective embryonic development; and third, others such as endometriosis and presence of hydrosalpinges. The assessment of endometrium for the intrauterine abnormalities is a core part of evaluation as it may influence the complex process of embryo implantation. Nowadays, a routine 2D and 3D ultrasound is considered as a preferred tool for the assessment of endometrial thickness and its vascularity, but there is high prevalence, about 40 to 50% of unsuspected intrauterine lesions such as uterine synecdoche, uterine septum, endometritis, and uterine polyps in asymptomatic patients, which were diagnosed by hysteroscopy in the numerous IVF studies. The presence of such intrauterine lesions may have a significant impact on the embryo implantation as well as pregnancy outcome in patients even after treatment of their infertility. As compared to transvaginal sonography, hysteroscopy allows us to directly visualize the unsuspected lesions and to undergo its treatment in the same setting. Aim and objectives. To evaluate the use of hysteroscopy in the assessment of uterine pathologies not evident on ultrasound and hysterosalpingography in women with previous one or more IVF failures, and second, to determine whether correction of such pathologies during hysteroscopy improves clinical pregnancy rate in these women. My study was retrospective randomized study done at Vardha Test Baby Center, a unit of Obstetrics and Gynecology department at JNMC and AVBRS Savangi Meghewardha. Duration was of 1 year. Sample size was 180. Inclusion criteria: women aged 45 years of age, women who had undergone one or more embryo implantation failure in previous IVF cycles, women having normal uterine findings on transvaginal sonography or HSG. Exclusion criteria: women aged more than 45 years, women undergoing first cycle of IVF, and women with the already diagnosed intrauterine pathology. The written informed consent was taken prior to procedure explaining all the details, and selected cases were subjected for hysteroscopy. Hysteroscopic findings such as endometrial adhesions, endometrial hyperplasia, and polyp and fibroids were diagnosed and treated accordingly with its corrective procedures. These patients then underwent repeat IVF treatment in the next cycle, and the pregnancy outcome of all these patients were recorded by measuring their beta HCG level on day 14 of embryo transfer. The early scan means 2 weeks after positive beta HCG test showing live pregnancy with the cardiac activity was recorded. The data was compared for a positive outcome of IVF treatment post hysteroscopy with that of the control subjects. The hysteroscopy was performed in 90 subjects and 90 patients were taken as a control with almost similar demographic parameters. This is the table 1 showing the demographic distribution of patients in both the group. Mean age in years and the mean duration of infertility was not significant in both the groups. Previous one IVF failure was more in the non-hysteroscopy group, and previous more than one IVF failure was more in the hysteroscopy group. Table 2 showing the distribution of various hysteroscopic findings in hysteroscopy group. 54 patients, that is 60% of the patient, had normal hysteroscopic finding, while 36 patient, that is 40% patients, had abnormal hysteroscopic findings. 16% patients had endometrial polyp, 8.3% endocervical polyp, 16.7% patients had endometritis, 33% patients had intrauterine adhesions, 8.3% patient had submucous myoma, 8.3% patient had T-shaped uterus, and similar for the uterine fundal septum. Table 3 showing the IVF cycle characteristics in both the groups: mean number of oocytes retrieved, mean number of oocytes fertilized, and the mean number of embryos transferred. The difference between both the groups was not significant. Table number 4 showing the patients with abnormal hysteroscopic findings and positive beta HCG. 24 patients showed positive beta HCG out of 36 patients in abnormal hysteroscopic group. Positive beta HCG was seen in 46.6% of the patients in hysteroscopy, while 40% patients in non-hysteroscopy group. GSAG was seen on transvaginal ultrasound in 36.6% patients in hysteroscopy and 33.3% patients in non-hysteroscopy group. Cardiac activity on ultrasound was seen in 30% patients in hysteroscopy group and 23.3% in non-hysteroscopy group, which was statistically significant, means the p-value was less than 0.05%. According to literature, some of the authors support the idea of performing hysteroscopy after recurrent embryo transfer failure, whereas some authors do not. Seneke et al. Reported the uterine abnormality in approximately 50% of the cases, such as cervical abnormality, endometrial polyps, and submucous myoma, after hysteroscopic evaluation in those patients who had undergone 2 unsuccessful ART attempts. Elistrophe et al. Reported such abnormalities in around 44% of his cases. Bacchus et al. Also diagnosed intrauterine abnormality in around 43% of the cases. Similarly, Demirol et al. Also noticed hysteroscopic intrauterine abnormalities in 26% of cases. All these intrauterine abnormalities may affect implantation in several ways, such as abnormal vascularization, chronic inflammation, and uterine contractions, which ultimately results in IVF cycle failure. Conclusion: in this study, hysteroscopy was able to detect around 40% of intrauterine pathologies, which were undiagnosed by other conventional methods such as USG and HSG. And we noticed clinical improvement in IVF success rate post hysteroscopy 33% versus 23.3%, which was statistically significant. So according to the result of our study, hysteroscopy should be offered to all those women with the previous 1 or more IVF failure, because some clinically undiagnosed pathologies can be detected and treated, and it will help for the success of the subsequent IVF cycle, which will help to reduce financial burden and the mental stress due to repeated failures. These are my references. Thank you.
Did you want to take up?
Yeah, so thank you. Thank you, Dr. Meenakshi. Nice article on a topic with a paramount importance. So I would just want to ask few things. What are the comorbidities you have taken in your account? Like BMI, the patient is having previous hormonal assessment. Any difference in both the groups?
Ma'am, I tried to match all the factors in both the groups.
So your both the groups were baseline characteristics like the BMI, they are no longer different.
Whether there are any obese patients and non-obese patients, that is she wants to ask.
Dr. Meenakshi, you are not audible.
Dr. Meenakshi.
I think.
Hello?
Okay,
Yeah,
sure.
yeah.
Am
Yeah,
I
Mary-
audible
Yeah.
now?
Yeah,
Yes,
yeah, yeah.
Mary
Now
is
you're
asking a
audible.
Stop
question.
share.
You can stop sharing it.
Please stop
Okay,
share.
okay, sir. Stop share.
Now the discussion session is starting. You can stop share.
Okay, okay, as I have stopped share.
So, Dr. Meenakshi, I was asking whether there are any confounding factors in your study in both the groups, like obesity.
No, ma'am, I tried to minimize, to keep all the parameters in the equal category so as to prevent the confounding factor in the study.
Okay.
Like
So I've
very obese
included
patients.
both. Yeah, speak up.
I had excluded very obese patients with the BMI more than 14, then all I had excluded from the study.
Okay. And you have included both primary and secondary infertility cases?
Yes, ma'am. Both the factors, both the primary and as well as secondary infertility were included in the cases.
So any difference in the rate of abortions in a secondary infertile patients?
Ma'am, rate of abortion was more in the primary infertility patients as compared to secondary infertility.
I don't think there's a
No.
table for that. Is there any table for that also? You have
So
compared it.
actually, sir, it was there in the article that I didn't include in the slide.
Okay.
Actually, I have your article. I didn't find on the data of any slide like abortions, whether there are any
Yes,
difference in the primary
yes,
or
ma'am. There was one more table in the article, table number 6, which was showing the clinical pregnancy rate and the miscarriage rate.
yeah.
Only 4 studies in the article they had mentioned their abortion, their miscarriage rate.
No,
Two RCTs and two
I just
NRCTs.
want in your study, whether the secondary infertile patients you have taken, all the secondary infertile patients in both the groups, were having, baseline any difference in the abortion rate in both the groups? Not after your IVF, before
No,
that.
ma'am.
So, group 2 were having more abortions rather than group 1, or they are.
No, ma'am. There was no statistical significance difference.
What was the anesthesia given for this? Always done in an office hysteroscope, or you have done operative hysteroscopy?
No, sir. We didn't do office hysteroscopy.
So it was all in operation theater.
Yes,
Proper
sir. It was
anesthesia.
in the operation theatre under proper anesthesia.
What is the duration between hysteroscopy and the next IVF cycle?
Sir, just after hysteroscopy, after 1 month, we posted for embryo transplant. About 1 month.
Already stored, embryo was stored.
Yes, sir. Yes, sir. We did OM pickup first,
Yes.
and then we posted the patient for hysteroscopy and next embryo transplantation. Embryo transfer.
Meenakshi, in the context of hysteroscopy and IVF failure, it is always like hysteroscopy is not advised even by X-ray for implantation failure. They say when you can get a good 3D scan and you can see the complete picture of the uterine cavity, there's no need to go for an invasive procedure like hysteroscopy. The only condition where you will find a hysteroscopy useful is a difficult embryo transfer. Suppose you had a difficulty in your cycle of failure of IVF procedure like embryo transfer, then a hysteroscopy will help you to find out those curved cervices. Suppose there'll be ridge in the cervix, all that type of conditions you can actually correct with your hysteroscopy. So just doing a diagnostic hysteroscopy, that polyp you can actually find out with a 3D ultrasound. That such big polyps which are going to cause an implantation failure can be identified. So this study is actually against whatever the X-ray is saying, and the other, it's even in fertility sterility, there's a study which said doing a hysteroscopy just to increase the implantation capacity is not advisable at all. So that's why this study becomes very important, because you are showing when you do a hysteroscopy, your IVF success rate is much more compared to without a hysteroscopy. So the message goes across like any IVF procedure, do a hysteroscopy, check out the endometrial cavity, and then you will go for an IVF. So that's almost contradictory to what the journals are saying, like fertility sterility and guidelines like X-ray are saying.
Yes, ma'am.
She has said about,
because
Madam Charna, she said in rural area. Rural area.
So even in rural area, the cost factor is going to be high. When you do a
cost will be high, but very good
anesthesia.
sonography machine and 3D sonography may not be available. So that is one thing.
Is that so? Is that so?
Ma'am, actually, I included only patients who have normal USG and HSG finding. Even after USG, even after HSG, no pathology, no intrauterine pathology was detected. And even after that, there is repeated failure. That's why we posted the patient for hysteroscopy.
For an endometrial factor, 3D ultrasound. It's not a 2D ultrasound.
Yes.
So that's what sir is saying.
Scan was available at your center?
Yes, ma'am. 3D scan is also available at your center. And even after that, if the pathology was not diagnosed, then the patient were posted for hysteroscopy. With all those patients who had already diagnosed USG finding and HSG abnormality, I excluded from the study.
See, when you have a subtle abnormality like an endometritis, there are no treatment options available. So how will a hysteroscopy help you to actually increase the success rate? A polyp which is big enough, you will do a hysteroscopic procedure, which is seen in an HSG, you will do. When you see, you will see Asherman's if it's quite, the additions are there. You will see those defects in your HSG when you're doing that. So probably the interpretation of your ultrasound and HSG should be much better so that you can avoid more hysteroscopies. Is that okay?
Yes, ma'am. Sure.
With endometritis, if you cannot just put it in the next cycle.
You can't. You will have to know what organism, because nowadays they've got the testing like for the organism also, and they do the genomic testing and all that. So there are facilities available, and endometritis cannot be cleared with a short course of antibiotics. It will not help you to increase your IVF rate at all.
Yes, ma'am. But with the hysteroscopy, we can also send the basically endometrial sample for the further testing. We'll diagnose the thing and then treat accordingly.
Then as Atul sir said, you cannot transfer the next cycle. You cannot transfer the next cycle. It will take minimum 6 to 8 weeks to correct an endometrial biome.
We have to give antibiotic and then post for the next procedure.
Oh, it depends on the procedure, you will do the transfer then. Okay.
Yes, ma'am. After the correction of the pathology, then the patient will be posted for the embryo transfer next.
Patient might be wanting that they want immediate result, but that is not the ideal way of doing that. You might
No,
get
sir. Yes, sir. We had explained the patient what was the intra findings. Then we had to treat them properly and then proceed for the next cycle.
mention that when you have further studies when you are doing.
Okay, sir.
So when you are doing hysteroscopy in your patient, as you are saying, you are doing it in a OT. So the other
Yes, ma'am.
causes of your IVF failure, like hydrosalpinx or endometriosis, you have not gone for laparoscopy in any of your patient. If your hysteroscopy is normal, you don't want to see what are the other causes of, 1 or 2 IVF failures in your patient.
Yes, ma'am. We diagnostic hysteroscopy was primarily done for the primary infertility patients. That too we had done,
No,
but
no.
not all the patients.
No, you have done laparoscopy for those patients who are having normal hysteroscopy, whether it is a primary infertility or secondary infertility in your hysteroscopy group, to see why she is having, 1 or 2 IVF or more IVF failures. As you have
No,
mentioned,
ma'am.
3 causes of IVF failure can be there, embryo transfer failure can be there.
Ma'am, actually, in this study, I didn't include the laparoscopy cases. I included only hysteroscopy cases.
So the 40 patients who are not having any problem were not diagnosed with any, why they are having the failure of IVF.
Yes, ma'am. Only hysteroscopy was done in this study.
Ideally, it should be a combination procedure when you are doing
Combination
it.
procedure it should be there.
When you are doing an NSH, you are doing an
Anesthesia.
operating theater.
Patient is going to OT, pre-anesthetic checkup, and all has been done for the patient.
You
All
just
is-
put in a scope and just find out whether it is there or not.
Yeah, if you find the hysteroscopy normal, then you could put a laparoscope to see whether the tubes are normal, endometriosis are not there.
Yes, ma'am.
Okay, Dr. Meenakshi, you have excluded obese women as well as you have excluded women more than 45 years of age. So we want to ask you
Yes,
why
sir.
so? What is the thought behind that?
So because if the age is more than 45 years, it may affect the quality of embryo also, quality of oocyte as well as quality of embryo. And I had to evaluate finally the pregnancy outcome in terms of positive beta SAG and TVS finding means positive pregnancy. So that would have acted as a confounding factor in my study. That's why I excluded all the patients age more than 45 years.
Okay, okay. And what about obesity?
Sir, BMI may also have the similar impact on the pregnancy.
Okay. Now with this, you would miss more sample size actually. Okay,
Yes,
okay.
sir.
Okay, Dr. Atul, Dr. Nidhi.
See, it's a good paper, but as everybody discussed, there are other methods to find out before doing hysteroscopy. Especially rural area, it's acceptable that after 1 or 2 you can do it. But in it's urban area where everything is available, it's better to go for 3D sonography or other findings and then go for hysteroscopy. Hysteroscopy is no doubt a very routine thing. It is done most of the things. So when before starting IVF also people are doing it just to find out. But correction and after correction, some time has to be given for whatever pathology you have found out, and then go for second embryo transfer. That is my
Agreed. So I think Dr. Sharmila, you want to ask anything else?
Dr. Madhuri is there.
Madhuri ma'am, आप
Comment करेंगे?
It was an excellent presentation, and as it is pointed out by sir also, what we should go next. And at the same time, we heard Madam Sadhna Desai also that we need not stick to our guidelines, RCOG or X-ray or all these guidelines. We should have our own guidelines, especially in a rural setup, because we want the maximum benefit out of the minimum, spending and efforts. So that should be the guidelines. And these papers are meant to know people that you can do this way also and that way also. And it is your own experience that you think what is good and what is bad. So that experience you should develop. So you should be, very, very clear in your concept.
Discussion
So
like
is
this
my
will also
comments
help
to
you.
you.
Discussion like this is also useful. So it's complimentary for you to start this session. We might start in the Journal of Midlife Health also.
Yeah.
Yes. Okay. So nice of you. So nice of you, sir. Yes. So
Just
I think,
yeah, ma'am. Yeah, ma'am.
no, I just wanted to thank Dr. Atul Bhai Munshi, Dr. Nidhi, Dr. Charmila, and of course our presenter, Dr. Minakshi, and the other presenter. What's her name? Other presenter, Maria?
Dr. Manisha.
Nisha,
Manisha, and another one,
Dr.
Meenakshi.
Meenakshi.
Minakshi. Both are speakers.
M, both are
So
M. Madhuri, Meenakshi and
yes, that's
Manisha.
why, and
3M.
then my
M,
MOUs, Sunil and both Pragna, they are all very kind to me. So we are doing this program very well. And of course, I cannot, forget Maria and Aarti, who are helping me in and out, all MOCs and me, to make this very, very successful. And this is the 9th episode. We are very happy for this healthy discussion and our sharing experience with even authors. So this will really give us a good, other people who want to replicate this, what you say, research work, can give the good experience to share next time when we get such type of paper. And
all the best for your future endeavors.
thank you, sir. Thank you,
Maria,
sir.
thank you for everything.
Thank
For
you,
And
sir.
some reply.
Thank you, Madhuri
and,
ma'am, such an
and
opportunity.
even Dr. Sadhna Desai and Usha Krishnan madam, I really appreciate them to be here with us. And Atul sir also, I really appreciate you to be here with all
Thank
of
you
us.
very much.
So thank you
Thank
very
you,
much.
everyone.
Thank
Nidhi, thank you very much.
Thank you,
you,
sir.
everyone. Thanks. Shall I end this?
Thank you, ma'am.
Yeah.
Yes, I think so, madam.
Yes.
Thanks.
Thank you. Thank you, everyone. Thank you. Thank you.
I'm ending this meeting for all. Thank you.